Yes, good afternoon. Thank you very much, Joe, for the introduction and for the invitation to join, which is always easier to accept when you can get on a bicycle or local transport to get to an event rather than get on a yet another aeroplane. So I think my role in this session can be to set the scene and give the kind of more international or even global kind of landscape, and then that can lead into some of the more national level insights and experiences. So I have start with this slide. So just to agree amongst ourselves, why are we here? I mean, it's because the value of mental health in this stage of life is extremely critical. It's when the adolescent during adolescence is when individuals are developing their not just the brain cognitive development, but also the more social development around social interaction and learning, emotional intelligence, and so on. And of course, that development in the social emotional environment is very much affected by the environment in which young people are growing up. So adverse exposure to family conflict or violence or abuse, poverty, can all have effects on that cognitive and emotional development. And the broader socioeconomic conditions, the neighborhood, or kids who are brought up in war, in conflict settings, and so on, obviously will have a very profound potential impact on the in adulthood. So that's sort of why we're here, and I thought we could start with some basic questions around what is it that influences mental health and well-being. So that's dealing with not just the risk factors, but also the protective factors for child and adolescent mental health. Then what are the consequences when those of exposure to adverse risk factors? So the negative consequences, which we can measure through disease burden and other metrics. And then, of course, what can we actually do to address those risk factors and burden of disease statistics? So very much the public health approach to the topic, even though you're mainly clinicians. I think a key point is that we want to do as much as we can to prevent people coming to see you in the first place. So starting with this first question about the influences on mental health and well-being. So we can split that down into individual attributes, not just the genetic and biological makeup that we each have, but also individual differences in our social and emotional intelligence. Then we have the household environment where children and adolescents are growing up. Absolutely critical to have a supportive home environment. And the same is true for school environments, school positive learning environments. Obviously, again, have a very immediate effect on the child's development. So if we think about school environments where bullying is a problem versus schools where it is not a problem, that is an obvious example. And then these broader aspects, which might also extend to, for example, the culture, the attitudes, the social attitudes towards people with disabilities, for example, including mental, psychosocial disabilities, varies very much from culture to culture, may shape the way that people see themselves in a bad light or a less bad light, depending on those influences. So these are some of the factors. And in a recent Lancet commission on global mental health and sustainable development, you can see how this can be, sort of mapped out, different trajectories, taking a kind of early life course approach, which looks at the various. See if I can get this thing to work. Yeah. So we can see three trajectories here. This red one, poor mental health. This one is an at-risk trajectory, and then the more mentally healthy trajectory. And we have both the risk factors down here. So starting right even from preconception through to the perinatal and postnatal period, infancy, school age, and adolescence. and at different stages we have different types of risk factors. So we know the importance for in psychology we're taught about the importance of attachment theory and how critical that is, not just for the physical but also cognitive development of in infancy. Whereas by the time you're in school, it's maybe around problems with substance misuse and behavioral problems that are exhibited, which can be risk factors. And remember that for every risk factor, there are protective factors. So, it's red light, green light. And so we can think about how, for example, mother-infant stimulation is the opposite of the insecure attachment as a risk factor. And similarly, having, for example, life skills, so socio-emotional learning amongst adolescents in schools is the kind of antidote to, to some of the issues around here. So this is one way of kind of conceptualizing some of these risk factors, and of course we can extend it, because a vital point about adolescence is that it's the precursor to adulthood, and if you get things right or wrong, that will have a clear effect on the adulthood. We know that, for example, around 75% of prevalent of mental disorders have their genesis or onset in adolescence. So it's extremely high proportion. So if we can sort of extend the arrow, keep on going, and many of the protective or risk factors that might present themselves at this early stage in life, in childhood and adolescence, will have knock-on effects. So the problems that you might face in childhood, which lead into problems in adolescence, let's say substance use, then might then show themselves into worse, scholastic achievement, less likelihood of getting a job, so higher risk of unemployment, which then has a impact on the likelihood of running up debts, and so on and so on. So there is this kind of very much life course approach that we need to think about, even though we're focusing in at this early stage in the life course. The knock-on effects are very evident. And then I'm not going to talk about, everyone else is talking about the HBSC study, so I think I'll leave that for others. And we already heard a couple of presentations earlier in the day on different aspects of the HBSC study, but we are extremely lucky in the WHO European region to have this mine of data. No other region has anything like this. So this is really important source of international comparable evidence on these determinants or risk factors, as well as the protective factors, some of which are mentioned there. So I think we'll hear a bit more about that in this session. That's my understanding. Instead, I thought we could. I thought I would just dwell a bit on this instead, which is adverse childhood experiences, or ACE. And so you can ask these questions prior to your 18th birthday. Did you have any of the following issues? And just like I was saying, the exposure to one or more of these adverse childhood experiences has very important, potentially important and enduring or lasting consequences into later adolescence and into adulthood. So, for example, the evidence from Mark Bellis and others who worked on this suggests, for example, that compared to individuals without adverse childhood experiences, the chances of various negative or adverse outcomes are much higher. So comparing no ACEs versus people with 4 or more, you can see there's the odds ratios here. So 3 times more likely to be a current smoker or having had sex under the age of 16, 6 times higher chance of having used drugs, more than 10 times more likely to be problem drinkers. And then you see the last one, and it's 49 times more likely to have ever attempted suicide. So a huge difference there. And then if you do the counterfactual analysis and looking if those ACEs weren't there, if they hadn't been exposed to those experiences, what would be the consequent public health effect? How much would smoking, for example, be reduced by without those exposure? And it was around 22%. This is the one that dwells on this, just to kind of finish this part of the story. But if we look at the issue with suicide, so it sort of goes up, obviously, with the more adverse childhood experiences you have, the more there's like a dose-response relationship here. In fact, it's almost exponential, as you can see, as you go up towards 6 or it's pretty much linear, actually. It's a bit exponential towards the end. So this is both looking at the childhood suicide attempts and then adult suicide attempts, and you can see the increases in the population as you have more and more of these exposure to ACEs. So I think this is pretty striking findings and very interesting research, and shows that there is ACE is a very strong and powerful predictor of subsequent outcomes, not just for mental health, but also physical health as well. Okay, time for a question. So this was a question that we put at the recent regional committee, where all the WHO member states come together. We had a sort of a round table or a lunchtime event. So we'll ask you the question we asked them on the day. So in low and middle income countries of this WHO European region, so Western Europe, Eastern Europe, and Central Asia, where does self-harm rank as a cause of death amongst 10 to 19-year-olds? So, you know, this is where you would have some clever, app which, you can do some online polling. But let's have a show of hands for answer A, 12th. Any? Okay, we've got one. Any more? Any more for A? 2, 3? No, this is both sexes together, not gender. So, okay, who's going to go for B? Okay, 1, 2, and who's going for C? Okay, large proportion. Okay, so most people think it's fourth. So in fact, the answer is B first. It's the leading cause of death amongst 10 to 19-year-olds. This rather busy looking slide is showing the answers here, actually. It was one of those illustrator guys doing this whilst we were doing this session. So you got all the results here. So we actually had much higher score than that. We had about 80% of people thought it was fourth. About 10% or less thought it was first, and the rest were down here. So this is brought out by this chart here. So this is showing the percentage of total deaths of 10 to 19-year-olds due to suicide. There's actually around 4,000 deaths in between the age of 10 to 19 for the European region as a whole. But this is converting those deaths into the proportion of all deaths in that age group. And you can see a huge variation. And the average is about 15%. It's 15% of all deaths in the European region, but you can see how it ranges from below 5 to more than 20. Depending on the specific countries, and some of the highest ones are we've got Sweden, Norway, Finland, but partly because rates of death due to other causes, of course, are extremely low. But there's other countries that we know have very high rates of suicide, generally in adults, but also in young people, including Lithuania, Kazakhstan, and places like that. Okay, so this is the consequences, you could say, of, suicide is an extremely complicated phenomenon, and it's due to so many risk factors. Some of the risk factors that I've sort of highlighted, like the adverse child experiences, are among the more important factors, but we know that it's, again, there's individual, there's social, and there's some broader environmental factors that can influence the rate of self-harm and suicide in populations. So this is just to summarize this figure here. This is the more than 4,000 deaths, and you can see how it's obviously goes up more in this age group, but also look at the proportion of those deaths. This is broken down by boys versus girls. This one at the top is showing using kind of global burden of disease estimates, and so adding up all of the estimated prevalent cases of conditions in the population. So again, we could sum that up and come up with a number like 17 million kids in the European region have one or more of these conditions, which equates to nearly 1 in 5 or 20% of the population of 10 to 19-year-olds. So it's extremely prevalent set of conditions if we include the neurological and also substance use disorders. Okay, so what can we do? This is moving on to the third of the questions. And I guess the first thing to mention is, well, what do we want it to look like? And I'm sure there's lots of models around. This is one I saw and liked, so I'm putting it up here from 2010, which is this asset model. But this is what we're basically talking about. If we're responding to those known risk factors and protective factors, what does the world should look like? So it should look like this: that there is decent housing and standards of living, there is access to health promoting environments, including schools and neighborhoods, and there's a decent education. So these will have protective effects and enable the promotion of social cohesion, social capital in this age group, development of socio-emotional intelligence and learning skills, and therefore enable positive health promoting behaviors, including healthier eating, better physical activity, and so on. So that's the sort of utopian vision, right, that we want to move towards. And it's always important to sort of be clear about that. But also I think there are a number of very important sort of principles or approaches that we need to keep in mind when designing policies and plans and so on. So some of them are listed here. I won't go into a lot of detail in all of them, but perhaps one I need to define a bit more is the dimensional approach. I've already discussed the life course approach and shown the importance of that. It goes without saying in a conference like this that we need to use interventions that are evidence-based, and it's also self-evident that we need a multi-sectoral approach. A health system or health sector approach is totally inadequate, not going to be enough, even though many governments seem to think that it does fall very much into the responsibility of health and are not looking beyond that sectoral response. So let me just say something about what I mean about the dimensional approach. It's basically just to say that we're all on a continuum, we're all on a spectrum of between wellness and illness at any one time, and people with mental illness or psychosocial disability, they still have levels of mental health, but they're just on a different level than us. So basically this is sort of challenging the well-trodden, more categorical approach to to thinking about mental health and mental illness. So it's not a case of that this person here, they may be just 1 point away on some scale, and this person counts as depressed and this person does not count as depressed. That's really not very useful from a public health point of view. It might be from a clinical point of view, and that's why we have things like ICD and I'm representing WHO. I'm not trying to dish ICD. I'm saying that has its own purposes for reinsurance and making sure that people do, for example, are identified and therefore have legitimate access, eligibility for receiving care and support. But from a public health point of view, so much of the emphasis is on this side of that we forget about about these dimensions. And of course, this is dealing with different aspects. And so it's not so much the case in places like Denmark or Scotland, or of course, there's very advanced mental health promotion and prevention plans and policies. But the further east you go in Europe, the less you see being paid attention to this. And it's all about this and not even much about this. It's pretty bad. It's pretty bad over here. There isn't a lot of a recovery-based approach. So it's basically just, I use this quite a lot, to try and emphasize the need for certainly policymakers to, and just like for just the same picture is like, rather than waiting for problems to present to you as clinicians, we really have to do a lot better on this side of the continuum. In terms of the evidence, I think Torben is going to talk about some of the evidence, but just to say there is, of course, lots of evidence out there, and there are lots of reviews. We've already heard a number of systematic reviews. This is another one that was done by one of our WHO collaborating centers, Margaret Barry, who some of you may know, looking at the situation in and beyond Europe. But this wasn't a systematic review. It was more a narrative review, because I guess a lot of the need is the problem with systematic reviews is they give you an effect size and say this is what the evidence tells you, but and it's based on well-performed research studies. But when it comes down to it, what do countries need? They don't just want a kind of effect size from some systematic review. They want to know about good programs that have been shown to work and be scalable. And are cost effective. So this is what we kind of more looked at, and including the implementation issues. So we know, for example, that doing socio-emotional learning programs in schools, if you don't do it well, it's kind of a waste of money. So there is a whole set of criteria, the implementation criteria, which are very, very important at a programmatic level. Anyhow, the focus of this, as it was of course to look at where is there good evidence, look at these implementation issues, and including requirements for scaling up. And it focused in on school-based interventions, community-based interventions, and digital interventions. So you can see where the kind of most of the evidence is falling. Did a big review of this, and able to kind of, on the basis of that, come up with some fairly good, strong policy recommendations, as well as scientific recommendations about where is the weight of evidence, but also which programs really have been, let's say, developed initially in the US or in Australia, but then being used in the European context with some success. So this is what the kind of evidence that is useful from a national policy point of view. So distilling some of those reviews and coming up with a basic set of interventions. This covers some of them in as few words as possible, and it's covering this kind of continuum that I was talking about, starting with, I would say, protection, actually. So I was talking about adverse childhood experiences and how fundamental that can be in shaping trajectories, life course trajectories. So child protection laws are, I mean, it goes without saying, but really, how much is known about the effect of those laws, and even their implementation is patchy. Again, the more east you go. Under promotion, life skills programs, there is certainly sufficiently robust evidence, not just on effectiveness, but also cost effectiveness to justify its scale up, as long as it's done well. Then we come into the prevention area, not just of risk factors like alcohol and other use, alcohol, drug, and other use disorders, but also huge opportunities in the digital health space, of course, here as well. And then when we come to the care and treatment, I'll mention a couple of those just in a moment. But this is where we're talking about how to better identify and manage common conditions in not just in specialists, so sort of by psychologists or psychiatrists, but in general healthcare settings, and by that I would include pediatric care as well. So these are some using this continuum, some examples. So WHO and UNICEF, for example, are currently developing a new kind of intervention package, very much focused on mental health promotion and prevention in adolescence, called HAT, Helping Adolescents Thrive. So that should be coming in 2020. This is other things. This is WHO's already existing intervention package for suicide prevention. And then for the identification and management, we have something called MHGAP, which is a kind of set of decision-making algorithms for use by non-specialists in primary care and so on. So I'll give you an example of a couple of these. This is Live Life. So here is the forming the young in their life skills, early identification. Of course, we know we were hearing a bit about that earlier. media reporting, and so on. So it's sort of packaged together as a set of things which countries should be seeking to include in, preferably in a national level suicide prevention strategy, or also within a child and adolescent health strategy that countries might have. The MHGAP thing, this is an example. It's modular. So there's for example, a module on child and adolescent mental health conditions. You can there's an e-version on you can download onto your phones to give a sense of what it basically takes you through the assessment and management of developmental and also behavioral conditions in childhood and adolescence. A pediatrician in Slovenia 2 weeks ago said, yeah, but this is all for, this is for developing countries, right? This is for Africa, Asia. I said, well, what makes you think that? I mean, why do you think you're above, helping train your GPs, given that there's a 1-year waiting list in Slovenia to see a specialist like a psychologist? This is the solution to your problems. So it's a very simple, integrated set of clinical decision algorithms. So you can find out more by either downloading the app or going to the MHGAP website on WHO. So to finish, so I think, risk factors, determinants is the starting point, of course, for discussion. And it is a very complicated, bewildering. There are so many different risk factors, and you might think from a clinical point of view, well, what can I do about it? I'm waiting for the problems to come through my door and do what best I can. But I think having a stronger awareness of the different, an appreciation of those different risk factors might help, to uncover what it is, the underlying reasons, and enable you to work with other professions, maybe with social workers or psychologists, caseworkers, whoever it is you're coming in contact with. If you're working, for example, in multidisciplinary teams, then this is very, very critical. I've sort of particularly picked out ACE as a strong predictor of those negative outcomes in adolescence and in beyond. And of course, this point about the implementation, the sort of policies and practices need to span this spectrum and be implemented across different sectors. So this helps to set the scene. So thank you very much for your attention. And thanks, Wilf, my son, who came today to join me because he's doing a personal project on adolescent and sleep. So we came for this morning and he's still awake, even whilst his father is talking. So thanks very much. We've had a good day.